Hi, I'm Dr. François Ricard. I am an osteopath, a PhD, and I am the director of the International Madrid School of Osteopathy. Today, I would like to talk about the manipulative osteopathic treatments of the sciatica and the lumbar disc prolapse. In PubMed, there is more than 36 scientific publications on the effectiveness of HVT manipulations in case of lumbar disc prolapse, published between 1998 and 2018. It is important to know the different etiologies of low back pain and sciatica. We can distinguish the non-inflammatory mechanical causes that are usual indication of osteopathic manipulative treatment. The inflammatory mechanical causes are rheumatic arthritis and non-mechanical causes as fracture, bone infections, tumors, and so, which are contraindications to manipulation. A substantial heterogeneity exists among prevalence of low back pain. It does exist a large country prevalence for low back pain. According to SWARD, the prevalence is 75% in athletes versus 31% in non-athletes. To Freimeyer, 40%, for Merlino, 1% to 58.1%, Jordan, 1% to 3%, Sanjin, 81.4%. The reactional hypermobility by neurological mechanism is due to the medulla sensibilization, which affects several metameres. Facilitated segment is responsible for segmental hypotonia of a deep spine muscle, which allows the overlying hypomobile vertebral segment to pass from active amplitude, limited by antagonist muscular tone, to passive amplitude, limited by the disc, capsule, and ligamentous system. This reactional hypermobility, added to the disc sprain, is an aggravating factor for the nerve roots irritation. Lumbar pain in forward movement of the trunk is related to ERS somatic dysfunction, but it is due to hypermobility inflection of the overlying vertebra. Lumbar pain in backward movements is related to FRS dysfunction, but it is due to hypermobility in extension of the overlying vertebra. Genetic mutations, anaerobic infection of the disc, and structural damage of the end plates are responsible for a decrease of disc blood supply and proteoglycans degeneration that produce water loss, dehydration of the disc, loss of hydrostatic pressure, and loss of disc ability to support the actual load of the body. These last elements generate a non-enzymatic glycation that produces weakness and tears of the annulus fibrosus. The disc prolapse orientation. The disc hernia can be central, the most frequent, paramedial or internal, foraminal, extraforaminal external, or lateral. We can clinically distinguish two types of lumbar disc prolapses: subligamentary disc hernia or content disc prolapse with discogenic low back pain and sciatica, transligamentary or exclude disc hernia or not contained disc prolapse with acute sciatica without discogenic low back pain. The first step of the osteopathic diagnosis consists in determining if it does exist a differential diagnosis. Based on anamnesis, inspection, neurological and orthopedic examinations, images examinations, X-rays, CT scan or MRI, and blood tests, the osteopath needs to determine whether the osteopathic manipulative treatment can be indicated for the patient's condition or if it is a contraindication that prohibits or modulates the manipulative treatment. If it is contraindicated, the patient is referred to the appropriate specialist, rheumatologist, traumatologist, oncologist, etc. If the osteopathic treatment is clearly indicated, the osteopathic diagnosis and examination are carried out following the appropriate protocol of treatment for the patient's condition. Contraindications to manipulations can include pathologies as traumatic, as fractures, rheumatologic or Reiter syndrome, ankylosing spondyloarthritis, bone infections, bone tumors, vascular disease arteritis, phlebitis, neurological tumors as neurinoma, visceral pathologies that produce referred pain to the low back. The first step of the osteopathic physical exam is the postural examination. Two AP postures imbalance can be anterior scapular imbalance, posterior scapular imbalance or asthenic posture, lateral imbalance by shortening of the lower limb, responsible for a functional scoliotic adaptation. The stabilometric examination by measuring the pressures of the feet and the body, as well as the anteroposterior and lateral oscillations, can indicate the type of postural imbalance at the same time as the type of foot problem and the need for the patient to wear insoles to correct the fit and the overall posture. The goal of the insoles is to displace the disc prolapse away from the inflamed nerve roots. The statistical relationship between levels of lumbar disc herniations and postural imbalance in 698 patients demonstrates that posterior scapular imbalance is the most frequent in case of lumbar disc herniation. In a population of 698 patients with lumbar disc prolapse, low back pain and sciatica, there was absence of short leg only in 3 cases, 0.43%. A short leg was found associated with a disc prolapse in 99.57% of the cases. In lumbar disc hernias, the pathognomonic clinical sign for the use of insoles is the pain in standing upright static position. Thermographic exam is interesting in osteopathy. This patient presents a left sciatica and discogenic low back pain by disc prolapses L4, L5, and L2, L3. The somatic dysfunctions are C5 on the right, rib 1 on the left, rib 2 on the right, rib 3 on the left, T8, T12, L2, L4, posterior ilium on the right, and left anterior torsion of the sacrum. In case of sciatica, the peripheral neurological examination includes to determine the importance of neurological disorders, sensitivity examination in dermatomes, motor examination, study of tendon reflexes, study of muscle strength, global or specific muscle testing. It can be completed by an electromyogram to appreciate the type of importance of the deficit. The first step of the physical examination in osteopathy is to study pain in active movements, in forward bending, backward bending, side bending, and rotation. The summary of the clinical case will be noted in a star chart. There are many orthopedic tests for the diagnosis of low back pain and sciatica. Some are used a lot and others less. Tests that are used routinely include 𝐻EM test or nerve root shear test in standing position, Butler slump test sitting, leg straight rising supine, Braggart test supine, Nacklash test prone. The sensitivity and specificity of each test are very variable. One of the best tests is the slump test. It is advisable to use a cluster of tests looking for the positivity of the test to get a more reliable idea. The gold standard for the diagnosis of disc prolapse is the MRI. The total MRI exactitude for the disc prolapses is 85%. It is imperative, before to perform HVT for herniated disc, to have a precise idea of its three-dimensional position and to know which anatomical elements are affected. These T1 and T2 MRI in sagittal and transverse sections show a subligamentary paramedial disc prolapse at L4, L5 with compression of the dural sac. These T2 MRI in sagittal and transverse sections show a central and paramedial exclude transligamentary disc prolapse at L4, L5 with compression of the left L5 nerve root. These T1 and T2 MRI in sagittal sections show an L5 S1 central disc prolapse with compression of the S1 nerve roots. Observe the italic S aspect of the compressed nerve root due to the mass effect of the herniated disc. According to 𝐩𝐴 these greater lesions of the disc have a major capacity of being reabsorbed by the body. In 80% of the big disc extrusions, there is a 50% size reduction. However, some patients are recovered for the disc extrusion without any change in size of the disc extrusion. According to Upton and McCormack, multiple crush syndrome in the pathway of the sciatic nerve and its branches is very frequent in case of distal paresthesias. The impingements most common area in case of low back pain with sciatica are foraminal transverse ligaments for the nerve root, anterior sacrum foramen for the nerve root, piriformis for the sciatic trunk nerve, soleus muscle tunnel for the tibial nerve, tarsal tunnel for the tibial nerve, and head of the fibula for the peroneal nerve. Various levels of these prolapses are very frequent, and in this case, the major problem is to determine which level must be treated. For this reason, we must search for the most facilitated and painful spinal level and for a positive Bell sign. The Bell test is positive if thumb pressure on the facet joint on the side of the sciatica trigger the usual pain in the lower limb. The Irvine-Court symptomatic triad for somatic spinal dysfunction include myalgic cord impalpation, myotome, localized pain and cellulitis with the skin pinch roll of the cutaneous rami, dermatome, spinous process pain during palpation for the sclerotome. The basis of the osteopathic examination is to look for and identify the somatic dysfunctions of the patient's body in relation to low back pain and sciatica. Some tests are global tests that look for areas of tissue modification associated with somatic dysfunctions, while others analyze the loss of segmental movements and abnormal couplet movements to determine the specific parameters of correction and the manipulation. Some of the tests used are the following: tapping test sitting or standing, analytic movement test sitting, rotation mobility test sitting for L4 and L5, Mitchell's Sphinx test prone. During the acute phase, drugs are indicated: non-steroidal anti-inflammatory, corticoids, and painkillers. At the same time, the osteopathic applied treatment protocol include direct and semi-direct HVT for sacroiliac joints, lumbar roll HVT for lumbar spine, lift-off technique for thoracic spine, muscle treatment, spray and stretch for example, ligamentous treatment, and back school. The Bachman's flexion distraction is a mechanical treatment of the lumbar disc prolapse. Increase the height of the disc. It produces a suction effect that reduces the size of the herniated disc, decrease pathogenic intradiscal pressure, eliminate intradiscal metabolites and edema for the pumping effect, increases the space of the spinal canal by 16% and of the intervertebral foramen by 28%. It inhibits muscle spasm and reduces pain. These sagittal and transverse sections show an exclude disc hernia L4-L5 paramedial before and after osteopathic manipulative treatment. Note the significant reduction in size of the herniated disc in post-treatment. These sagittal and transverse sections show a transligamentory paramedial disc prolapse at L4-L5 before and after osteopathic manipulative treatment. Observe the reduction in size of the herniated disc in post-treatment. The reduction of size in herniated disc is frequent, but not systematic. 𝐕𝗏𝗄 indicates that in 68% disc hernias show a reduction of more than 30%, and in 48% it is more than 70%. SAL indicates that 36% patients have a decrease in the size of the hernia between 50 and 75%, and in 46% a decrease in size between 75 and 100%. Modic observed an 80% improvement in the size of the herniated disc with conservative treatment. The management of a sciatic neuralgia requires between 6 and 9 osteopathic manipulative treatments. Between each treatment, it is necessary to evaluate again the patient and to use the adequate techniques. In 92% of the cases, it is possible to avoid surgery and its complication. Except in case of contraindication, the treatment of choice is the conservative osteopathic treatment that should be proposed before any surgery.